Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. They will be useful to fourth year students for exam as well as when they start doing private practice. Today I'm going to discuss regarding one of the odd topic which is not uncommon, rather it is not rare also. You will see good number of time in your everyday practice. That is we call Brash Syndrome. B stands for bradycardia, R stands for renal failure, A stands for AVNODE blockade, S stands for shock, and H stands for hyperkalemia. All these things can be seen together in one person. Mainly what started first is difficult, but together when bradycardia, renal failure, AV node block, shock and hyperkalemia are together, it is labeled as Brash syndrome. So this is not uncommon as well as it is not rare also. So it is one of the disorder which can be seen in your everyday practice. It is no doubt not very common, but it is not uncommon also. So we'll be discussing regarding that under same heading, that is introduction, etiology, pathophysiology, clinical features, investigations, treatment, complications, etc. So what is Brash syndrome? This is a syndrome due to vicious cycle. So it is very important to understand that there is a vicious cycle. But there are certain things which are there. There are some drugs which are responsible. There is a renal failure. There is hyperkalemia. And there is hypotension, or we call shock stage. So there has to be one thing which is quite common, is medication. And these medications include two groups of drugs. One, beta blocker, and second, that we call as ACE inhibitors. So beta blocker, ACE inhibitor, and third drug, which may be one of the important drug to predispose this, is calcium channel blocker, particularly diltiazem and verapamil, which will produce AV block. So renal failure, already if it is there, it will give rise to hyperkalemia, and that hyperkalemia may be exaggerated because of drugs, as well as hyperkalemia will produce accumulation of potassium, which will aggravate AV node blocker action like atenolol, and hyperkalemia will further have synergistic effect with the AV node blockers to cause bradycardia and hypotension. And this hypotension can in turn worsen the renal failure. So what started first is difficult, but basically drugs, predisposing factor like hyperkalemia and renal failure, all this takes a part in a vicious cycle. So we have got five things together: bradycardia, renal failure, A for AV blocker, S for hypotension and shock, and another H, that is for hyperkalemia. So all these things are seen together, but what came first is difficult. So to understand that, this is two simple diagram. Indirectly it will help you to understand the pathophysiology, as well as it will help to understand the clinical presentation as well as etiology also. So I'll start with this. Later on also we'll get this particular in detail. Say a person is on a beta blocker, calcium channel blocker, these two drugs. Beta blocker will produce bradycardia and calcium channel blocker will produce AV node block. So bradycardia can be there. Bradycardia can predispose to. So calcium channel blocker as well as beta blocker can produce bradycardia. Will go from one side. So because of that bradycardia, you can have poor renal function because bradycardia will produce hypotension, and because of hypotension, renal perfusion will be affected, renal failure may be precipitated. And this renal failure will produce accumulation of drugs which are being taken, that is beta blocker and calcium channel blocker. As well as beta blocker is also known to increase hyperkalemia because it will shift potassium from intracellular into extracellular compartment. And this particular ACE inhibitor also is known to aggravate renal failure, and also it will aggravate hyperkalemia. Indirectly, what came first? We don't know. So, if we come to this diagram, so Brash syndrome is consisting of hyperkalemia, bradycardia, all these 5 things together. You have to start from one. Say person is on a RAS inhibitor, or we call ACE inhibitor or ARB. That will predispose to hyperkalemia, and that will predispose to renal failure. So renal failure will predispose to hyperkalemia. Now this hyperkalemia will have bradycardia and AV block if person is already on AV blocking drugs, like what we call as calcium channel blocker, diltiazem, verapamil, or beta blockers. So those drugs will further aggravate these two phenomena. It will aggravate hyperkalemia, it will aggravate bradycardia and AV block. And because of this bradycardia and AV block, you will have hypotension, shock stage. And that shock stage will aggravate renal hypoperfusion and will predispose to renal failure. Indirectly, this RAS inhibitors, AV blocking drugs is going to aggravate renal failure, hyperkalemia, bradycardia and AV blocks. And because of hypotension, shock, renal perfusion will end into renal failure. Now this vicious cycle, from where it started, is difficult. Even hypovolemia, any hypovolemia can trigger of renal hypoperfusion and shock stage, and then this vicious cycle sets in. So this is a vicious cycle, and that ends into bradycardia, renal failure, AV block, shock stage and hyperkalemia. So that together is called as a Brash syndrome. So what came first? Difficult. So renal insult, person is already on a drugs that accumulates in the body, will give rise to bradycardia and AV block. Bradycardia and AV block. Because of bradycardia and AV block, you will have hypotension, shock stage, decreased cardiac output, renal hypoperfusion, and renal failure will be precipitated. That will give rise to hyperkalemia, and hyperkalemia can also produce bradycardia. And hyperkalemia can aggravate the action of beta blocker, CCB. So this becomes a vicious cycle. So etiology wise, if we take now common medicines which are predisposing to Brash syndrome is calcium channel blocker, and again in calcium channel blocker we call which drugs blocks AVNODE, that is verapamil and diltiazem. Second group of drug is beta blocker, and among those metoprolol, carvedilol and atenolol. And third drug we call as a spironolactone, that is aldosterone antagonist, and that is going to increase potassium level. Beta blocker will also help in increasing the potassium level. Now in this particular situation, person who is either on CCB, beta blocker, spironolactone, and also I'll add one more, that is ACE inhibitors or ARB. So when these multiple drugs are together in a person who are already having a cardiovascular disorders, then so person taking a drugs which is going to produce AV blocks, 2 drugs, calcium channel blocker, beta blocker, and say his age is an old person, his kidney are vulnerable, and he is also prone to develop hypovolemia. All this can trigger of the syndrome, which can clinically milder than the syndrome itself, and that is the predisposing factors, or we call etiology. So person has to be on a drugs like CCB, beta blocker, spironolactone, and even I am adding ACE inhibitor, ARB drugs. And age wise, more common in the older people, more common in a person with a hypovolemia, and more common in a person who are vulnerable to kidney disease, like already at this age, diabetes, hypertension, all those are more common. Use of NSAID, etc. will also further aggravate the kidney damage, all those things. I have already explained this slide. So renal failure leading to hyperkalemia. Hyperkalemia will give rise to accumulation of AV blockers like CCB and we call beta blockers. Then because of that accumulation of those drugs, you will have a bradycardia and hypoperfusion, and bradycardia and hypoperfusion further aggravates renal failure leading to hyperkalemia, as well as these drugs will also aggravate hyperkalemia. All this is interlinking, and that is very nicely explained. I have already explained before this particular slide. So there is hyperkalemia and person is using AVNODE blockers. So pure AVNODE blockers effect plus pure hyperkalemia together will give rise to what we call as a Brash syndrome. So two things has to be there. Development hyperkalemia either because of drug itself or because of renal failure, and person has to be on AVNODE blocker, either CCB or beta blockers. These people will be more prone for Brash syndrome. This we have already explained in detail. Again I will be repeating. Person who are on ACE inhibitor, ARB, they are more prone for renal failure and hyperkalemia. And if already those people who are already on beta blocker and calcium channel blocker, so the level of this non-selective beta blocker will give rise to hyperkalemia. Also CCB will give rise to bradycardia, and beta blocker will also give rise to bradycardia. So hyperkalemia can further aggravate the action of beta blocker and CCB, and then this beta blocker will produce fall of blood pressure, hypotension, renal hypoperfusion, further aggravate renal failure, which will further increase hyperkalemia as well as increase the level of beta blocker and CCB in blood, giving rise to the toxic effects of beta blocker as well as CCB. So this becomes then vicious cycle. So it is like a tornado. So vicious cycle involving a Brash syndrome. So two things are very peculiar. Use of these drugs like ACE inhibitor, ARB, spironolactone, beta blocker and calcium channel blocker. And these are the most common drugs which are utilized in congestive heart failure. And person should develop hyperkalemia. And then this vicious cycle will develop. Same thing explained here. Drugs, either drugs producing toxicity or there is an increased level of drug because of renal failure. So because of drugs you get hyperkalemia, and because of drug you can get renal failure. So renal failure can be because of drugs or because of nephrotoxic drugs. And once the person develops a renal failure, hyperkalemia can be produced. And when the drugs are being used and person develops hyperkalemia, chances of AV blocks are more because of use of CCB like diltiazem verapamil, or because of use of non-selective beta blockers, and that will produce bradycardia. So hyperkalemia can aggravate the action of those CCB drugs etc. to produce bradycardia, and also directly the effect of CCB, particularly diltiazem and verapamil, can produce AV blocks. And this bradycardia and AV block itself will induce hypotension, and hypotension can be aggravated more by dehydration and sepsis. And because of hypotension, person can go into a shock stage and multi-organ failure. So this is the entire pathophysiology which can be there. Where it started and what will be the outcome will depend upon the involvement of the different pathophysiological factors. Same thing what is being shown here. There is one more thing which is being explained was lactic acid acidosis. Because of shock stage lactic acidosis, and lactic acidosis can further aggravate the shock stage, poor renal function, and renal impairment can also produce acidosis, etc. So same thing is explained here. Hyperkalemia, AV blocks, common factor leading to Brash syndrome. So two things has to be there: development of hyperkalemia and development of AV block due to drugs like CCB, beta blocker. And hyperkalemia can be because of drugs or say because of renal failure. And then together will give rise to hypotension, hypoperfusion, further aggravation of renal failure. And renal failure will give rise to two things: hyperkalemia as well as increased level of medication in blood, and that will give rise to toxic effects. So all this becomes a vicious cycle, and this can be seen by elevated level of potassium in blood, and ECG changes will be seen in electrocardiogram. Similar pathophysiology again explained, where it started, how it started. See, we can see here ARB and NSAID in combination can give rise to hyperkalemia. CKD can be worsened because of renal hypoperfusion, and this renal hypoperfusion is because of bradycardia and AV block, and this bradycardia and AV block is because of advanced age, CKD, liver injury. All this can aggravate decreased cardiac output. Now synergistic bradycardia resulting because of accumulation of AVNODE blockers, that is CCB and beta blockers, will give rise to vicious circle, will give rise to hypotension, shock stage, metabolic acidosis, and this metabolic acidosis will shift potassium, will further aggravate hyperkalemia, as well as CKD will also aggravate hyperkalemia. All this is a vicious cycle. Where it started, where it ends, depends. We have already explained you. So person will present to you with asymptomatic laboratory abnormalities to a shock stage and multi-organ failure, maybe in any one stage. By and large, the patient is elderly patient. Person has to be on a cardiovascular medications like CCB, beta blocker, ACE inhibitor, ARB, spironolactones, etc. And if he develops a dehydration, either because of decreased intake or because of excessive use of diuretics, now person will develop hyperkalemia. So person will have a potassium level more than 6, sometime even more than 7.5, and because of that you will get classical changes in ECG, that is peak T wave, wide QRS complex will be seen, and good number of time it may not be seen in an ECG, but blood level of potassium will be high, and we already explained this particular phenomenon. So person will have combination of symptoms like bradycardia, and this bradycardia may be because of AV blocks. Person will have signs of renal failure in the form of blood urea creatinine elevated, hyperkalemia. In ECG you might see AV node block, that is prolongation of PR interval may be seen. Person will have a hypotension and shock stage, and blood picture will show you potassium more than 6. So on investigations you demonstrate all these 5 findings: bradycardia, evidence of renal failure, on ECG AV block, shock stage, and blood will show you hyperkalemia. In ECG you can see that here it is very clearly shown you that person will have effect on PR interval, QRS complex and T wave. All this will be seen. You will have a tall T wave will be tall, QRS complex will be widened. This will be the two early signs. R wave will be, QRS complex will be widened, PR interval will be prolonged, and then P wave will disappear. So later on we will not be able to make out that there is an AV block. What we will see will be more of tall T wave, widening of QRS complex and disappearance of the P wave, and that is a sign suggestive of hyperkalemia. And when the hyperkalemia is very severe, we will see sine wave. So typical ECG in a Brash syndrome, that is severe bradycardia, peak T wave, flattening of the P wave will be characteristics in case of a hyperkalemia. So you can see that tall T wave, little widening of the QRS complex and P wave is absent, and severe bradycardia. The heart rate is 30. You can see the heart rate is 30. So you will have a severe bradycardia. So that is characteristics of severe hyperkalemia. Again you can see a tall T wave, wide QRS, and almost the P wave has disappeared, and severe bradycardia. So bradycardia, differential diagnosis. One, you have to differentiate hyperkalemia, other causes of hyperkalemia. We will have to differentiate like hypoglycemia, hypoxia, hypothermia, acute coronary syndromes, drug toxicity, raised intracranial pressure, infections, etc. These are some of the conditions which can mimic Brash syndrome. Now there are some life-threatening conditions like hyperkalemia, acute coronary syndromes, Brady bunch it is called. 3 drugs which are very commonly used in heart failure: beta blockers, diltiazem, verapamil and decoxin. And in a raised intracranial pressure, Cushing syndrome or Cushing sign, sorry, not Cushing syndrome, Cushing triad. So that will also show you changes in ECG as well as person will have a severe bradycardia. Deep symmetrical T wave inversion will be seen in CNS insult. That is one of the what we call as mimics. 4 causes of bradycardia: hypothermia, myxedema coma, myocarditis, endocarditis, travel bugs, dengue, malaria, typhoid fever, Legionnaire, etc., sleep apnea syndromes. And do not forget post-cardiac surgery, post-surgical in cardiac, particularly valve surgery, rupture abdominal viscous, particularly ectopic pregnancy. You can have a paradoxical bradycardia because of vagal response, etc. So this becomes a closed differential diagnosis. Now what is most dangerous one? Most dangerous one is hyperkalemia. So you will have to correct hyperkalemia by immediate, if there is a life-threatening hyperkalemia, correct immediately by giving calcium gluconate, followed by insulin drip with dextrose, or you can use nebulizer albuterol. And if after that still hyperkalemia is not coming under control, we might require a hemodialysis and even a transcutaneous pacing may be required. Not common, usually it is avoided. So does not. Now if this does not give a results, you can consider epinephrine, which will increase the heart rate also, and it will also drive potassium inside intracellular shifts, and that will help to reduce hyperkalemia. Now, if person has got a precipitating factor as hypovolemia, which has given rise to shock stage, always give a IV fluids, particularly a balanced fluid rather than normal saline. So balanced fluid will be better. If person is on a calcium channel blocker or beta blocker or digoxin, try to reduce the dose or stop and do the toxic level in the blood. Look for the toxic level in the blood. So that will help to reverse the toxic effect of calcium, CCB, beta blocker and digoxin. These are the three notorious drugs, and do not forget to add even ACE inhibitor. So, because of severe bradycardia, you can use atropine, epinephrine, dopamine or cardiac pacing. To stabilize the cardiac membrane, calcium gluconate. To correct the hyperkalemia, insulin drip with dextrose or albuterol in the form of nebulizer. By and large, sodium bicarbonate is not commonly being utilized, furosemide is not commonly utilized, and even potassium, what we call as resins, potassium binding resins, which binds potassium and reduce the potassium level. Those are not commonly being utilized. The most common, which is safe, is insulin drip in dextrose. Rarely we require a dialysis if it is refractory. This is for correction of potassium. This is for correction of potassium, and this is for increasing the heart rate. For increasing the heart rate. So, correction of hypovolemia, for hyperkalemia, calcium gluconate, insulin plus dextrose, beta agonist like albuterol in the form of inhalers, particularly nebulizer, and last is hemodialysis. And for bradycardia, isoproterenol, or you can use even atropine, dopamine, epinephrine, and last is cardiac pacing. So bradycardia and shock can be benefited by epinephrine drip, and to reduce the renal failure, correction of blood volume and correction of bradycardia and shock stage is necessary. And to reduce the side effects of drugs, do the blood level, and if there are toxic level, reduce the dose or stop and change over to the other drugs. So hyperkalemia will be corrected by IV calcium gluconate, insulin glucose drip, albuterol in the what we call as inhalation forms like nebulizer. Soda bicarb is usually not commonly being utilized. Diuretic is not commonly being utilized, but dialysis can be in refractory cases. And for bradycardia, atropine does not typically work, but still you can try atropine, IV calcium gluconate, epinephrine, dobutamine, and last is pacing. And fluid status should be corrected and discontinue the nephrotoxic drugs. And while treating for hyperkalemia, you should be aware of hypokalemia also. And while treating bradycardia, you may respond well to aggressive early non-invasive therapy rather than pacing, and treat the underlying cause. This is a basic treatment for Brash syndrome. There is something called as a pH guided resuscitation. Patient who requires a large volume of fluid resuscitation, assess the metabolic condition, that is acid base imbalance. If a person has got a non-ionic metabolic acidosis like uremic acidosis, Alkalinization by isotonic bicarbonate will be helpful. If person has got an acute metabolic acidosis, acidify by using 0.9% saline. And if there is no pH disorders, you can use ringal lactate, plasmolites or balanced crystalloids. Reassess again the volume status as well as electrolyte and pH, and then maintain that. We already mentioned repeatedly that main important complication which is dangerous one is hyperkalemia. So first volume status should be corrected, and to find out the volume status, bedside ultrasonography for inferior vena cava collapsibility should be done. Physical examination should be done. You resuscitate for volume status and target high normal bicarbonate, correct metabolic acidosis, and if there is no metabolic acidosis, you can use ringal lactate, and if there is a metabolic acidosis, you can add isotonic bicarbonate. And for hyperkalemia, you can use furosemide or you can go for dialysis. So this will be the thing. Complications mainly because of bradycardia, renal failure, AV block, shock and hyperkalemia. Person can develop cardiac arrhythmias and person can die. So in short, good number of time we face this particular problem because person is already on the drugs like ACE inhibitor or ARB. He is on a beta blocker. He may be on calcium channel blocker like diltiazem or verapamil. Plus he is an old person. He may be diabetic, hypertensive, he may be on NSAID, etc., which also may be predisposing factor. Or he may be on a diuretic which can produce hypovolemia. So any one of this can trigger off, and person who are old person who are on ACE inhibitor, beta blocker, CCB or spironolactone with diuretics, these people will be more prone for hypovolemia, shock stage, renal failure, will go into hyperkalemia, and because of renal failure, blood level of all these drugs, beta blocker, all those CCB level will be elevated, and they will start producing toxic effect in the form of severe bradycardia. AV blocks, AV blocker drugs are being utilized, that is CCB and beta blocker, particularly non-specific or non-selective beta blockers, and they will develop a vicious cycle, and hyperkalemia can produce lot of complications. So this is in short regarding a Brash syndrome. I think this will be very helpful to you, at least in your theory side. Once in a while you can come across, and when you are doing a private practice, someone, old person who is on a group of drugs for cardiovascular disease like ischemic heart disease, congestive heart failure, or person is having a dilated cardiomyopathy, etc., and suddenly you come across a person with severe hypotension, shock stage, he is having severe bradycardia, he is on this group of drugs, he has developed hyperkalemia, that is classical Brash syndrome. So thank you very much for taking out time. I know that your time is valuable, and I appreciate this for spending some of the time with me. Thank you once again. Do not forget to press button like if you like this particular lecture. Subscribe, and you can share with your friends. And again, at the end, this is one of the common things which can be seen in a person who are on treatment, particularly the old age person with ischemic heart disease, congestive cardiac failure. They will be on this good number of drugs. Do not forget to look for those. It can be lethal, and person can have high mortality.